Preparation for cardiovascular examination. Perform procedure in a quiet room. Adequately expose the area to be examined. If the patient is male, strip to the waist. Use a piece of cloth or towel to cover a woman's breast. Patient can be examined either supine, sitting, and then leaning forward or lying on his left side to enhance subtle findings. Sit or stand on the right side of the patient. Simultaneously inspect and palpate the patient, followed by auscultation. Perform hand hygiene before performing the assessment. Wash the hands.
The doctor greets the patient and offers a seat upon coming in. Apart from introducing him or herself to the patient, the doctor must ensure the patient's privacy. The medical practitioner should ask about past medical history, and the patient must elicit the chief complaint if there is any. After which, the patient will be asked to wear the examination gown and sit on the examination bed.
Good morning, Sir Ron. I am Doc Laura. So for today, we're going to do cardiovascular assessment. So may I ask you to please lie down on your back. So is it okay if I'm going to touch and palpate your neck?
Yes.
I'm just going to expose.
Inspection and pulsation of the carotid arteries. Carotid pulsations may be seen medial to and higher than the base of the sternocleidomastoid muscle. Use the right thumb to palpate the right carotid artery and the second and third fingers to palpate the left carotid artery. Do not palpate simultaneously. Describe carotid arteries as to amplitude of pulsation, rhythm, equality of pulsation, and consistency of the walls.
Please turn your head to the left.
If with neck vein distension, measure the jugular venous pressure and the central venous pressure. Place ruler 1 on the sternal angle and align it with something in the room that you know is vertical. Place ruler 2 at an exact right angle to ruler 1. This constitutes the horizontal line. Move ruler 2 up and down, maintaining horizontal position so that its lower edge rests at the top of the jugular distension. Read the vertical distance of ruler 1, which is the jugular venous pressure, and add 5 cm, which is the distance from the sternal angle to right atrium, to get the central venous pressure. A normal CVP should not exceed 10 cm of water. An increased CVP suggests an increase in right atrial pressure. Inspection and palpation of the precordium. First, observe the precordium. Normally, it should be flat. In patients with congenital heart disease or in heart diseases with ventricular enlargement acquired during childhood, the left precordial area bulges forward. Second, locate the apex beat or apical impulse. Stand on the right of the patient. Shine the penlight tangentially on the precordium and locate the apex beat. If visible, put an X mark over it. Note, apex beat is visible only in about 20% of normal people. Place the finger pads on the second and third digits over the visualized apex beat and note its amplitude, either it's strong or weak, and rhythm, whether it's regular or irregular. If apex beat is not visible, palpate by laying the palmar aspect of the right hand within the vicinity of the usual location of the apex beat. If not palpable in the supine position, palpate the patient in the left lateral decubitus position or sitting and leaning forward. Note, apex beat is palpable only in 50% of normal adult. Once palpated, mark it with an X using the ICS and the LMCL measured by a ruler. As landmarks, give the exact location of the apex beat, or determine the distance in centimeters from the mid-sternal line to the X mark.
Okay, I am now going to do the auscultation.
Auscultation of the precordium. First, count the heart rate and identify the rhythm. To carry this out, position the patient as in palpation. Place the diaphragm or bell of the stethoscope over the apex and count the rate per minute.
Hold your breath.
The rate varies normally from 60 to 100 beats per minute. Describe if the rhythm is regular or irregular. Second, identify the first and second heart sounds. Place the diaphragm on the base and apex or vice versa. As you listen to the heart sounds, gently position your left index and middle fingers on the carotid artery. The upstroke corresponds to S1, which is the beginning of systole. The other sound is the S2. Listen for S1 and describe its intensity, either soft, normal, or accentuated. Normally, S1 will be more intense over the apex. Listen for S2. Normally, S2 will be more intense over the base. Listen to the interval between S1 and S2, and the interval between S2 and S1. Note for any splitting of S1 and S2. Technique to elicit splitting of S2. First, place the diaphragm over the pulmonary valve area. Towards the end of inspiration, listen for the splitting of S2.
For the findings of cardiovascular assessment, the jugular venous pressure is 3 centimeters above the sternal angle with the head of bed elevated to 30 degrees. Carotid upstrokes are brisk without bruit. The point of maximal impulse is tapping 1 centimeter lateral to mid-clavicular line in the 5th intercostal space. S1 and S2 are crisp. At the base, S2 is louder than S1. At the apex, S1 is louder than S2. There are no murmurs or extra sounds, no mitral stenosis, and aortic regurgitation.
Good morning po, I'm Dr. Lakab. I'm going to perform a peripheral vascular system assessment today. Can you please request you to relax?
Begin by proper inspection and palpation of both arms from the fingertips to the shoulders. Note for the size, the symmetry, areas of edema, pigmentation, pallor, hair loss, varicosities, and lesions. Assess the skin temperature of the hands and lower arms with the sensitive backs of your fingers comparing both sides. If you detect unusual coolness and temperature difference, check further up the arms. Next, assess the brachial pulse. Flex the patient's elbow slightly, then with the thumb of your opposite hand, palpate the pulse at the antecubital crease just medial to the biceps tendon. Next, palpate the radial pulses and compare their amplitude. If you suspect arterial insufficiency, feel for the ulnar pulse. The pulse of a normal artery may not be palpable. To help determine the patency of the ulnar artery, perform the Allen test. Place your thumbs over the radial and ulnar arteries and tell the patient to clench his fist. Tightly then firmly compress the arteries between your thumb and fingers. Have the patient open and relax his hand. Note the color of his thumb and fingers, which should be pale, then release the pressure over the ulnar artery. Repeat these steps but over the radial artery.
Sir, I'm going to be assessing your lower extremities. Is it okay if I expose your legs?
Inspect and palpate both legs. Note for the size and symmetry, areas of edema, pigmentation, pallor, and hair loss. For the nails, check for color, deformities, lesions, and capillary refill. Next, assess the skin temperature of the legs with the sensitive backs of your fingers comparing both sides.
Sir, is it okay if I palpate your inguinal area?
Next, palpate for the femoral artery, which is palpable below the inguinal ligament, midway between the anterior superior iliac spine and the symphysis pubis. Describe the pulse as to its amplitude, rhythm, equality, and consistency of the walls. Next, palpate for the dorsalis pedis artery. Its pulsations are palpable on the dorsum of the foot just lateral to the extensor tendon of the big toe.
Please lie on your belly.
Lastly, palpate for the popliteal artery, whose pulsations can be felt in the tissues behind the knee. Again, describe the pulses as to its amplitude, rhythm, equality, and the consistency of its walls.
Peripheral pulses of the patient's legs are regular and equal or symmetrical. The consistency of the walls are also soft. Amplitude for the femoral, popliteal, dorsalis pedis, and posterior tibial pulses are graded 2+ on both sides.